So my name's Andy Davies from the University of Southampton in the UK. And I guess when will we see changes to frontline therapy for diffuse large B-cell lymphoma? I think it's a really interesting question. It's one of great research interest. I think first of all, in early stage disease, we've already seen a shift in the way we approach this with a reduction in the amount of chemotherapy that we give patients and really our adoption of a PET-guided approach. And a number of trials have demonstrated that we can give a reduced number of cycles of R-CHOP chemotherapy. Some of those have used a PET-guided approach, some have not, but I think it's really important that we can reduce patients' exposure to chemotherapy and significantly reduce toxicity, and with no compromise on efficacy. In patients with advanced stage disease, how we improve on R-CHOP chemotherapy, I think is a great one of interest. And I think we've looked at patient stratification based upon clinical parameters over the years with some limited success. And I think, we still see that R-CHOP chemotherapy remains the standard of care. And we've tried looking at intensification with high dose chemotherapy. We've tried increasing dose intensity by changing our R-CHOP 21 to R-CHOP 14 without success. We've tried using new infusional approaches and additional drugs, such as the dose-adjusted EPOC study, which showed no benefit over R-CHOP chemotherapy. So all of this has been somewhat disappointing. However, we are starting potentially to be able to stratify patients with DLBCL based upon biological parameters. And although I think our first attempts that have used transcriptional profiling based upon the ABC and the GCB cell of origin model, and we've seen that the drugs that we have added to R-CHOP chemotherapy have not been all that successful to date. So we've looked at adding bortezomib, lenalidomide, or ibrutinib, all of those which potentially are focused towards the ABC subgroup without success. And it may well be that we haven't classified patients sufficiently and that there's actually greater diversity in the molecular heterogeneity, or it may well be something to do with patient selection, or it may well be to do with the drugs that we use. But actually, we're beginning to refine the biological classification, and the series of papers that we have seen based upon exomic analysis for mutations, based upon copy number variant and structural variants, to classify DLBCL into a broader number of potential molecular subgroups really opens the doors for recognizing vulnerabilities within the molecular makeup of the DLBCL, and that these vulnerabilities may be potentially targetable with additional drugs. So I think we are at the verge of being able to modify our therapies based upon refinement in terms of patient selection. I think in those patients who have double hit or triple hit side translocations involving MYC and BCL2 and or BCL6. I think many people already feel that R-CHOP chemotherapy probably is inadequate therapy, and that many people prefer to use intensified regimens or even the dose-adjusted EPOC regimen. So we are selecting out some groups already based upon the biology. But I think as we consolidate this molecular understanding of DLBCL much better, then I think it would be much better at being able to refine our frontline therapy for DLBCL. So watch this space.